They were talking about, they got a question like for somatostatin and on which cells does it work, and their option had like pituitary option, they had gastrin option, like parietal cells and stuff like that, doc. Something like that, I remember, doc, something.
Yeah.
So when you said somatostatin turns off everything, is there a specific cell that it works on, doc?
No, actually it works.
Specific area?
It works on so many cells at the same time. So, for example, somatostatin can inhibit the parietal cells. It can also, the main one is the parietal cells that it's inhibiting. Why? Because if you inhibit the parietal cells, you decrease the HCLs, you decrease the pepsin. Yeah?
Okay.
But that's not the only one though. Also, the pepsin, this guy, okay, is produced by the sheath cells of the stomach. And also, the somatostatin is able to inhibit the sheath cells of the stomach. Okay?
Okay, doc.
Makes sense?
Yeah, doc.
Okay.
Can't wait to do questions on this.
Well, GI is lovely. It's just like amazing.
Okay.
Gastrointestinal secretory
doc.
products. Let's speak about intrinsic factors that is produced.
Can you record the class now?
I already started. So,
Oh, okay, awesome.
the intrinsic factor, there is something called intrinsic factor. Just please, man, during the break, the moment the break starts, just tell me upload. I will upload it right away. So,
Yeah.
parietal cells are located in the stomach. It's important to know a few things about them though. Where are they located and how they look like? I will show you a picture now, and I will teach you how to identify them. The video is up. Man, is there a website in the US that people can find apartments on, or you don't have such a thing there?
No, doc. We use this thing called Airbnb, doc. You know Airbnb?
Yep, this guy.
Yeah.
I see.
Did you find anything, doc, close to the area?
Yeah, I found actually not that expensive, man.
Yeah.
So, histology of the stomach.
But once you get matched and everything, right, doc? Try to get in touch with the other residents and see if anyone wants to share an apartment. That would be better, I guess.
That's what I thought. It will be much cheaper. And man, seriously, we don't use an apartment that much. We will be in residency.
I know, doc.
It's just a place to sleep.
So, yeah, doc.
Oh, yeah. Okay, so they show you this histological...
Yesterday, my brother also interviewed in this university in Staten Island, though, some university program.
Which one?
In New York, Staten Island. I don't know the name of the program. I think it's a university program. It's a great program. So it went well, and if he matches in there, I'll come and meet you, doc.
That would
Because
be
I have to
great.
anyways go and do apartment hunting and everything for him.
Apartment hunting. Love it.
Yeah.
Well,
I went to Miami and I fixed the stay and everything, though, when I went.
is
When
it
he
in
got matched
Brooklyn?
last year.
Is it in Brooklyn or some other area?
So luckily, just 5 minutes away, there was a university apartment, doc. It's called at the one at University Center. It is like a posh dormitory type, doc. You know, he took a 1-bedroom apartment there, which was lovely in Miami. It was very good.
Well, that's good. Well, you know, man, even if well, wait a second. What happens if he does not match?
Usually, transitional years match 90% of the time, though.
Yeah, that's
We
what I
have a
think.
90% match rate. But if he doesn't match, then he has soap. In soap, he'll definitely get in something.
I see.
But I think he's going to match for sure, though.
Yeah, does he have a U.S. Citizenship?
Yeah, he's a citizen.
Done, man. It's like he has much higher chance. So
Yeah.
take a look at this. Can you see we have a blue cells and we have pink cell? Yeah.
Yep.
Blue cell are sheath cells. Pink cells, P for pink. Okay. Okay, good. So now comes the game they love to play with you. Take a look at this one. You can see this one. Of course, we are not looking at the nucleus. We are looking at the cytoplasm. Yeah?
Got it, doc.
So this pink cells is
Parietal cell.
Okay. So let's try to do this as well. Okay. Pink cell, this one.
Parietal cell
Blue cell,
as a chief cell.
pink cells,
Parietal cell.
this cell.
Which one? Doc? That's the blue cell. Chief cell. Sir.
Yes, that's one. Last one. This.
Is that a cell? Yeah, that's a parietal cell. Doc.
Okay, done. Good. Makes sense how to differentiate between the two?
Yeah, Doc.
Okay, so the next trick. This is one way they can ask you this question. The other way they can ask you this question is by showing you a picture like this one. You're like,
Yeah,
but I cannot see where is parietal cells and where is chief cells located. It's all about how deep. So let me show you. If the cell is located super deep in this layer, it's a chief cells, okay? If it's located
Okay.
in the upper region, it's a parietal cells, okay?
Okay.
Okay. So they say intrinsic factor is secreted by the parietal cells. Well, let me take a moment now to tell you how we absorb the B12. We absorb the B12 from first of all, we take it orally, yeah, with food. So the B12, when he comes,
With fish and everything, right? Doc? Dairy products and fish.
yeah, there is B12 in fish and meat. So B12 comes together with animal protein, okay? When it comes inside of our mouth, our salivary gland produces something called the R factor. It's not important. Anyway, it continues to the stomach, okay? The stomach acid is going to destroy the animal protein, okay?
Okay.
So now you have the B12 and it gets connected to the R factor. Where was the R factor produced?
In the mouth, Doc.
Okay. And now there is intrinsic factor released in the stomach, but it's not bound yet. These two are going to the duodenum. Inside of the duodenum, you have B12. Remember the alkalinization of the alkalinity
Yeah.
of the duodenum? So that is going to kill the R factor. Yes? So in the duodenum, the B12 is going to bind to the intrinsic factor.
Got it.
B12 intrinsic factor complex keep going until they reach the ileum, the terminal ileum. In the terminal ileum, they get absorbed. Okay?
Terminal ileum. Okay, Doc.
Yes. Let me just repeat for a second why the R factor was cleaved. Two reasons. First of all, the duodenum is pretty alkaline because of the pancreas. Yeah? Also, it has these enzymes that come from the pancreas. That helps to cleave it off. What I'm trying to say, if you decrease your oral consumption of B12, you can get B12 deficiency. Yes?
Yeah, Doc.
If you have no parietal cells, which make the intrinsic factor, you get B12 deficiency. Correct?
I'm sorry, Doc. If you don't have parietal cells, so parietal cells is from the intrinsic factor is from the parietal cells, Doc?
Again?
The intrinsic factor is coming from the parietal cells?
Yes.
Okay.
Parietal cells produce two things, HCl and intrinsic factor. Okay?
Oh,
Good?
I'll write it down, Doc, because over here they didn't give it cell-wise, right, Doc? Like cell, what each cell does, chief cell, parietal cell,
Yeah, absolutely.
they
So
didn't do that.
yeah, so let's just keep going here. If you have bad stomach, you are not going to have intrinsic factor, you get B12 deficiency. So, okay, done with the intrinsic factor. If you don't have pancreatic, in case of chronic pancreatitis, really bad pancreas, you will not have normal alkalinization, or normal enzyme secretion into the pancreas, which is going to lead to what?
Uh, 1 second, Doc. The bicarb, you're talking about bicarb right now, Doc. Isn't bicarb by the secretin, Doc? The S cells in the duodenum?
Can you repeat that, please?
You said pancreas helps in creating bicarb, right, Doc?
Yes.
But I thought it is because of the secretin cells in the duodenum, Doc, that gives more bicarb.
Well, the secretin cells increases the pancreatic bicarb secretion.
Oh, okay.
Got it?
Okay, doc. Understood, doc.
Uh-huh. Okay.
Understood.
Okay.
Okay.
So
You said when we have pancreatic problem, then we have less bicarb, and then we have less what though?
again, please. Less enzymes from the pancreas. Less enzymes from the pancreas. Like for
So it's not able to cleave the B12 in the R.
yes. So the R will be still stuck. That means you get a B12 deficiency, because for the sake of getting absorbed from the terminal ileum, you must have intrinsic factor on the B12. Yeah.
Yeah, but we have intrinsic factor, we have B12, but B12 is bound to the R.
Yes. So no. Well,
Yeah.
you cannot. The
We
B12
can,
does not have
yeah,
the key.
there's no connection, there's no bonding between the B12 and intrinsic factor.
Absolutely. Okay, so far we can see that if we have B12 deficient, we don't eat B12, we get B12 deficiency. Bad stomach, B12 deficiency. Bad pancreas, B12 deficiency. Bad ileum, an example in Crohn's disease, we have bad ileum,
Yeah.
no, B12 deficiency. Make sense?
Doc, why in stomach, doc?
Well, stomach, the parietal cells make intrinsic factor. If it is destroyed,
Oh, okay.
no intrinsic factor, no absorption. Make sense?
Okay, doc. Okay, stomach, yeah. Duodenum got it, mouth got it, yeah.
So the next thing we have here, they write about intrinsic factor, parietal cells, the stomach, vitamin B12 binding proteins required for B12 uptake in the terminal ileum. Autoimmune destruction of the parietal cells can lead to chronic gastritis and something called pernicious anemia, which is a macrocytic anemia due to the absence of B12. Yeah?
Yeah, doc, yeah.
Gastric acid can lead, is produced also by the parietal cells of the stomach, and they decrease the stomach pH because they lead to the acidity of the stomach, correct?
Yeah, doc.
So the gastric acid in the parietal cells is secreted by the stimulation by histamine vagal stimulation. So let's try to understand this point actually. If you take a look here, here is vagus. Vagus, we said, it stimulates the GRB to make us gastrin-releasing peptide, working in the G cells, making us gastrin, which can stimulate the parietal cells to make HCl. Also, the vagus nerve can work directly at the parietal cells to produce HCl. Also, the vagus nerve can work at the it can work at the directly at the G cells making gastrin. So the gastrin can lead to HCl production. Also, they can work in something called enterochromaffin-like cells, which produce histamine. Okay?
Okay, doc.
So, and that histamine will lead also to activation of the parietal cells. I want you to know this one thing.
So that's why we give H2 blockers, though, for histamine blockers?
That's correct, yes. I want you to know one thing here, it's important. This pathway with the histamine is much more stronger than this pathway without the histamine. Okay?
So the histamine pathway is more potent
Absolutely.
to produce HCl.
Yes.
Okay, doc.
Okay, good. So they say it increased by histamine vagal increase gastric acid by histamine vagal stimulation and gastrin. So, and decreases by somatostatin, GIB, which is the guy that was, remember, glucose dependent insulinotropic peptide.
There's an incretin, right, though? GIP?
Yes. And the prostaglandins as well, and secretin. Remember, secretin function was turn off the stomach, turn on the duodenum. Yes?
Yeah. I'm sorry, can you repeat it, though?
Which one?
Secretin. Secretin, can you repeat, though?
Yes, secretin says stomach off, duodenum on.
Okay, doc.
So it turn off the stomach phase and turn on the duodenal phase. Yes? And
Okay, doc.
it's produced by the which cell?
The S cell, though.
What about
Somatostatin is D cell, though.
excellent, good. So the
But
next
doc, I was thinking the turning off and turning on was this cholecystokinin, though, because
I told you.
It increases the sphincter of it increases gastric emptying. I mean, it closes the sphincter or something, right, doc?
Yeah, well,
So
both
is
of
it
them.
secretin or cholecystokinin, doc,
Both
which
of them.
turns off and off?
It's actually both of them.
Okay.
So,
Okay, doc.
okay. So let's take a look here. We have Pepsin. Pepsin. So regarding Pepsin, it's well, you tell me what is the color of the cell it's produced in?
Blue, doc. Blue.
What is it called? How do we call it?
Trypsins.
Okay. And is it located deep or more higher in the
It,
kidney?
it's deep, doc.
Okay. And what is the function of Pepsin?
The function of Fripsin is to digest the proteins, doc.
Okay. And yeah, so increased by vagal stimulation by acetylcholine and local acid. Pepsinogen is inactive. It's converted to pepsin in the presence of H, like the HCl stimulates it. So can you see here, HCl stimulate the pepsinogen to become pepsin, which is the active substance. Yeah?
Okay, doc.
Okay. Really quick. Cholecystokinin, secretin, all of them are in the duodenum, which help the initiation of the duodenal phase. Yes?
Yeah, doc. The secretin and the cholecystokinin.
Yes. The last one is bicarbonate. It's can be in the mucosal cells of the stomach, duodenum, salivary gland, pancreas, and the renal glands in the duodenum. I have one question for you. First of all, can you remind me, please? And this is a really high yield concept. How H. pylori can lead to an ulcer?
Yes, doc. H. pylori is between the mucosa and submucosal layer, doc. That's where it stays, and that's where it produces urease. Urease converts the urea into ammonia, and therefore it's making it less acidic. Therefore, it's making it more alkaline. And when it's more alkaline, the gastrin thinks that there's less acid, and it produces more acid in the stomach, and eventually that leads to ulcer, doc.
Yep, absolutely correct. Nice. Okay.
So, doc, over in this picture, doc, we have mucus and submucus, right, doc? Is muscularis between mucus and submucus, doc?
Again, please.
Is muscularis layer between mucus and submucus, doc? I thought it was mucus, submucus, and then muscularis.
Well, we have two muscle layer. If you take a look back here, the mucosa has a minor muscularis layer, which is not relevant actually. Where it is, yeah, muscularis mucosa, and again we have the actual muscularis, which is the real deal.
Okay.
Okay, so it's actually two layers.
And doc, these chief cells and parietal cells, are they in the mucosa or submucosa, doc?
Mostly submucosa. Most of the secretory glands are in the submucosa.
In the submucosa.
In the submucosa, yeah. Oh, are you asking about the mucous cells?
No, I'm talking about the chief cells and parietal cells, doc.
Oh, yeah.
Which layer are they present? Because from here, it looks like the parietal cells are in the mucus layer, doc, not submucous layer.
Let me check that really quick, just a second.
Yeah.
I think you are right, but I need to check it really quick. I think you are right. Just a second.
I remember I saw one NBME, doc, NBME 20, there was the picture, and they had arrows in the picture. So just want to make sure that I get it right.
Yes, just a second. Yeah, they say, okay, it's in the... okay, no, between the mucosa and the submucosa. Okay?
Okay.
Between the two.
No, doc. Can you show that again, doc? So present. They're talking about the muscularis mucosa, which is between.
I think you have a point. It makes sense that they will be in the mucosa because they need to secrete. I mean, if it was endocrinological, I would be like, no, it's in the submucosa, you know? But if it is exocrine, it must be in the bit itself.
But I thought you said that they are all endocrine, right, doc? It's not exocrine.
These ones here, yes, all of these are endocrine. Okay. Intrinsic factor, exocrine. Gastric acid, exocrine. Pepsin, exocrine. Bicarbonate, exocrine. All of these endocrine. Okay.
So this page is all exocrine, though?
Yeah, this is endo. to the blood. This is exo, to the lumen. Yeah. Man, it's to the
Okay.
lumen. These must be mucosa. These must be submucosa.
Okay, Doc.
Okay.
Got it.
So, okay. So let's speak about bicarbonate. It neutralizes the acid. Where the acid come from?
The chief cells and where does it come from, Doc? The gastrin.
Yes, absolutely. Well, not gastrin. Well, HCl. Yeah.
Yeah, HCl.
The gastrin is just a hormone. So bicarbonate increases by pancreatic and biliary secretion with secretin. Why? Because secretin turn off the stomach, turn on the
Turn off the stomach, turn on the duodenum.
done. So the bicarbonate is trapped in the mucus that covers the gastric epithelium, which is super important to protect the gastric epithelium from the acidity of the stomach. Yes?
Yeah, Doc.
Okay. Okay, so you can see the deeper layer have parietal cells, correct?
Yeah, Doc.
Wrong. It's three sheath cells. Deeper layer have the sheath cells, upper layer have parietal cells.
Oh, okay. No. My brain was on the Brenner glands. I was trying to see where is the Brenner glands. Is it shown
Wait.
in this?
Yeah,
Okay,
I don't
okay.
believe
Yeah,
they show
yeah.
it to you. So, okay,
Got
the
it, Doc.
sheath cells are deeper, parietal cells are upper, and enterochromaffin-like cells are the deepest. What was the function of these guys?
The endochromaffin-like cells. Is this the one that releases histamine, Doc?
Absolutely, it's the one that produces histamine, this one. Which pathway was
Yeah.
stronger? Was it the one with the histamine or the other one?
Hey, Doc.
Okay, does it bind to H1 receptor or H2 receptor?
I think we give H2 blockers. That's why it's H2.
Yes, because remember, when you dine with two people. Yes, so H2.
Yeah.
And the drug names all ends with dine. Yes?
Doc, which cells actually produce HCl? Is it the parietal cells, Doc, that produces HCl?
Yep, it's parietal cells. Remember, parietal cells produce also intrinsic factor. Yeah?
Okay, Doc. And they are present throughout the stomach, Doc?
Yes, they are throughout the stomach, but mainly they like to be at some location, which is the corpus of the stomach and the fundus of the stomach. Okay?
Okay, Doc. Okay, Doc.
Okay, so look what they write. Gastrin increase acid secretion primarily through its effect on the enterochromaffin-like cells, leading to histamine release rather than through the direct effect on the parietal cells. So as I told you, this pathway is the strongest, yeah?
Yeah, Doc.
Okay. So pancreatic secretion, now this topic is important. It requires, if you read this for 26 times, you will not understand it until you draw it. So I really highly advise you to draw this scheme. So the pancreas has a functional unit. In the kidney, we have the nephron, yeah? In the heart, we have the sarcomere. In the GIT, in the pancreas, we will have the acini, okay? In the liver, we have the acinus, the lobule, basically. And now we have the this acinus. Well, let's try to think what happens here exactly. So basically, this is the pancreas. This is the functional unit of the pancreas. Here we have some cells, okay? And here we have the duct that eventually is going to where? It's going to the duodenum, correct?
Yeah, Doc.
Inside of here, these cells produce the pancreatic juice, okay? The pancreatic juice, which is located at number 1, it will be really high in bicarbonate, okay?
Okay.
And really low in chloride. Good?
Okay. Okay.
Okay, so now it starts moving here. When it starts moving here, what will happen? What will happen that let me just do like this. So the chloride is going to be, there will be more chloride put in it. Yes? And more bicarbonate sucked from it.
Okay.
Okay, why this is important? It's important because if you have a really fast flow, what is going to happen to the amount of bicarbonate and the chloride? If you have a fast flow,
Less reabsorption, less secretion of chloride. So it will maintain its one doc.
Yes. Let's say that now you have a really, really slow flow.
There will be more exchange. Doc.
So that means it will be mainly chloride in it, not bicarbonate. Yes?
Yes, doc.
Okay, so look what they write. It's an isotonic fluid. When you have a low flow state, you are going to have high chloride. Make sense?
Yeah, doc.
When you have a high flow state, you are going to have high bicarbonate. Make sense?
Yeah, doc. 1 second, doc.
Mm-hmm.
So it's low flow rate, high chloride. Yeah, high flow rate, high bicarb, high flow. Yeah, got it, doc.
The clinical relevance of this thing. So when we produce an enzyme called secretin, for example, or cholecystokinin, we promote the secretion of the pancreatic juice. Yes?
Can you repeat it, doc?
When we produce, when the food reaches the duodenum, we will have plenty of cholecystokinin and secretin released, correct?
Right.
That will lead to plenty of what? What will happen?
Pancreatic juice. So you're saying the flow rate will be high?
The flow will be high, so what is going to happen to the
So
chloride?
it will have more bicarbonate, doc?
Absolutely. Yes, makes sense?
Okay. Got it, doc.
So during the gastric phase of digestion of the food, you are going to have a low flow, high chloride. But during the duodenal phase, you are going to have high flow, so that means you are going to have high bicarbonate. Make sense?
Yeah, understood, doc.
Okay. Nice. Actually, this concept is kind of difficult. It's good that you understood it quick.
Oh,
Yep. So the next one is alpha amylase. It's starch digestion. And I told you that the amylase can be secreted in an active form, and it comes from two places. The first is pancreas, and the next place was?
was the salivary gland, doc.
Yep, absolutely. Lipases from the pancreas can lead to fat digestion. You are like, what about the bile? Yes?
Yeah.
Let's imagine that you ate a piece of fat. This is a piece of fat. What does bile do, and what does the protease do? Yes? So let's take a look. Okay. So bile lead to emulsification of the fat. What is emulsification of the fat? It's cutting it into big
Cutting.
pieces. Okay? Big
Yeah.
pieces. So let's take a look at it. I'm just making big pieces. So this is big pieces, yeah? If you take one piece only and you try to put it under the, electron microscope or something, you will see something like this. This is a glycerol, okay?
Yeah.
And these are fatty acid. 3 of them. So we call it a triglyceride, okay?
Okay.
Good. So now we have a triglyceride. Now comes the what? The lipase, yeah? Which is going to do what? It's going to cut the fatty acid, okay? So now you have
Glycerol
diglyceride.
and fatty acid.
Yes. One by one. So it's going to get glyceride, monoglyceride, and then glycerol and fatty acid only. Yeah?
Yeah, doc.
Okay, makes sense. So the function of the bile is only for the emulsification, which is making big pieces. The lipase destroy these big pieces into smaller pieces. Okay?
So is this the Michel, doc? The chylomicron, Michel something?
Chylomicrons. Chylomicrons will precipitate in that. Basically, the triglyceride, the ones that are not ingested, they will... the micelles. Yeah.
Micelles, yeah, micelles.
The micelles. Yes. So the micelles are going to be emulsified by the bile, and some of it that are not directly destroyed in the by the pancreatic juice are going to make it inside of the blood supply. Yes. Basically they go to the lacteal, to the lymphatics, and then eventually reaches like to your thoracic duct and then to your blood, and there another type of lipase is going to face them. Okay.
Okay, doc.
Okay. So the protease is a protein digestion. We have a trypsin, chymotrypsin, elastase, and carbopeptidase. So secreted as a proenzyme, also called zymogen. To convert zymogen into an active enzyme, what should you do?
To zymogen. Okay.
Yeah, how to convert zymogen into a normal enzyme, active enzyme.
To cut the N and T terminals off?
Yes, absolutely. Good. So few notes. Elastase is totally excreted in the feces without any change. Okay?
Mm-hmm.
That means we can check fecal elastase to check the function of the pancreas.
Okay, Doc.
Trypsin. A trypsinogen is converted to trypsin inside of the duodenum. In case if we have a premature activation of the trypsin inside of the pancreas, we'll have pancreatitis.
Autodigestion. Yeah, Doc.
Yes. So now trypsinogen is converted to an active enzyme, trypsin, and that will lead to activation of other proenzymes. So the main one to activate is trypsin, and that guy is going to activate everybody else. Yes? So how does trypsinogen gets converted to trypsin? And I told you when you have a trypsin activated, it's going to activate all of the other enzymes. Chymotrypsin, elastase, carbopeptidase, it activates everybody else. Okay?
Okay.
So activation of other proenzymes and the cleaving of additional trypsinogen. So he also can activate himself. Yes?
Okay.
Into an active trypsin. Positive feedback loop. So how can we make enterokinase from... how can we make trypsin out of trypsinogen? Well, there is one enzyme that has three names. The first name is called enterokinase, enteropeptidase, and the brush border enzyme. They can use any of this. It's located in the duodenum and the jejunal mucosa, and it converts what to what? It converts the trypsinogen into trypsin. The trypsin is going to convert himself again, the trypsinogen into trypsin, and he's going also to convert other types of enzymes into their active formula. Yes?
So basically, let me repeat, Doc.
Mm-hmm.
The trypsinogen is converted to trypsin, which is an active form in the duodenum, by the enterokinase or the enteropeptidase. This is an enzyme that converts trypsinogen to trypsin, which is an active form. And trypsin is going to activate the other proenzymes, which are like elastase, trypsin, chymotrypsin and carboxypeptidase, right? No?
Correct. Yes. Okay.
And what is zymogen? So is it the inactive form of something, or what is it?
Yes, the proenzyme, the inactive form, we call it zymogen. Okay?
Okay.
Yeah, the inactive enzyme, we call it zymogen. When it gets activated, it changes its name. So let's speak.
And it's being activated by the HCl, right, Doc?
In the pancreatic ones, no. They are being activated by the trypsin.
Trypsin, okay.
Yeah. And
so does trypsin come and cleaves the N-terminal, Doc, in this, the zymogen?
Again? Yeah, the N and the C terminal, both of them.
Okay.
Okay, so carbohydrate absorption. Remember when I told you you ate the piece of bread? I told you that it was destroyed by what?
Piece of bread is destroyed by what?
Amylase, yeah?
Amylase, yeah, Doc.
So it was disaccharide, basically starch, and it was converted to monosaccharide. What monosaccharide do we have? We have a glucose, galactose, and the fructose, okay? So they write, they are absorbed by enterocyte. It's a must to know which electrolyte help you to reabsorb the glucose. The answer is sodium, okay?
Okay.
So glucose and galactose are uptaken by SGLT1. Are you having deja vu? Did we see this thing before?
SGLT1, right, Doc?
We saw SGLT2. Where was that?
In renal, Doc.
Yep. And we had a drug that inhibits it even, and that was used in diabetes, yeah?
Gliflozins, yeah, Doc.
Okay, so SGLT1 is located in the intestine. So it's a sodium-dependent co-transporter, which means you cannot get the glucose into your body if you don't have the sodium. Yes?
Yeah, Doc. Let me really quick just take a look, Doc. Just 1 second. So, yeah, it takes glucose and sodium. Got it, Doc.
Okay. So they say fructose is taken up via facilitated diffusion by GLUT5. So FFF, facilitated diffusion fructose 5. Okay?
Yeah, doc.
So this guy is kind of like odd because it does not use the same one as the two other monosaccharide. Yes? Two other monosaccharide use the SGLT1, but which is means sodium glucose cotransporter. But the fructose use the GLUT5. Okay.
Okay, doc.
They are all transported to the blood by GLUT2. Okay.
Okay, doc. 1 second, doc. Just trying to. So SGLT1 is for sodium and galactose. GLUT5 is for fructose, and they are both reabsorbed. They are all of them are reabsorbed by GLUT2, doc.
Yes, GLUT2, which means like see this two and see this one, all of them are reabsorbed here by the GLUT2.
Okay, doc. Okay, doc. GLUT2.
So deoxylase dust is a simple sugar that passively absorbed at the proximal small intestine. Passively absorbed, so it does not need energy. It does not need anything. It just reabsorbed. So why would we do that? Well, basically we give the patient the deoxylase and we check it in his blood. Okay.
Okay.
If it's present, that means that his enterocytes are good. Okay.
Okay, doc. So deoxylase is like a monosaccharide, though?
Yeah, it's a simple sugar, but it does not need a bump. It does not need need this. Okay, he just passively. Okay, so it's a way to check if the enterocytes are working or not. Yes.
Okay, doc.
Blood and urine level decreases with mucosal damage. Normal in pancreatic insufficiency. Why? Because it passes diffusely. It does not need pancreatic enzyme. Yes?
Yes, sir.
Okay. Make sense?
So carbs doesn't need pancreatic enzymes. Okay, doc.
Good. So, okay. Let me just take a look at this. Okay, let's take a little break. Welcome back. Okay.
So, doc, I had a question real quick, doc. So in anti-arrhythmic drugs, doc, like arrhythmias we have, right, doc? So is there any difference between the like few drugs only do rate control and few does the rhythm control?
I did not get that. Can you repeat it?
And anti-arrhythmic drugs, doc, we have class 1, A, B, C, class 2, class 3, class 4, right?
Yep.
So I was just reading in one of the explanations that class 1C, class 3, they are more of a rhythm control.
Yeah.
They act with, yeah.
I see. Well, you are not a cardiologist, so you don't have to know this minor details. But you must only know for this stuff that, class 1C is mainly for the supraventricular arrhythmia, not for the ventricular arrhythmias, okay? If we speak about 1B, you need to know that mostly it's post-infarction type of antiarrhythmic. For the class 1A, you need to know that it works on both, but it has severe side effects. Yeah? I mean, supraventricular and ventricular. So
doc, rhythm control meaning it is rate control is SNO AV node. Rhythm control is just prolonging the QT interval, right, doc?
Well,
so that.
It's not really rhythm controls mean it's making it back to sinus rhythm, in which you will have B, Q, RS, and T to be normal. This is what rhythm control means, putting it back into normal. Rate control is decreasing the heart rate. Like if it was 120, you make it back to 80, you know? That's rate control. Rhythm control is when, example, you have this. And instead of this, you get that. Okay? Okay,
doc. And doc, when we have a QT interval is prolonged, right? Like in dosagepons, why do they die with a ventricular tachycardia, though? Because
why they do what?
Why do they have a sudden cardiac death with ventricular tachycardia?
Well, when the heart is beating so fast, can it have time to fill?
No. But when the QT is long, that means it's repolarizing, right? Dog? QT meaning like
repolarize. Well, D and repolarization of the ventricle. Okay, so
So that's good, right, doc? It's the heart is not pumping massively. It means it's slowing, right, doc? The depolarization and repolarization is increasing the time.
Okay.
Prolonged QT meaning.
The prolonged QT is not the reason of death. The reason of death is the torsade de bois, which is happening because of the ectopic foci hitting the isoelectric line.
Okay.
Remember about the isoelectric line?
What is that now? Isoelectric line?
I will show you. So this patient on the right have a long QT interval. Yeah?
Okay.
So this is ectopic foci here. And the exact same ectopic foci will be here. Yes?
Okay.
So before a QT prolongation, when the ectopic foci hit, can it lead to contraction?
No.
Why?
Because it's in repolarization, right, though?
So refractory period, yeah?
Yeah.
What about now, when it hits this flat line, isoelectric line?
Okay, then it can go.
Yes. So this will become something like this.
Okay. Okay. The impulse will come in. Okay.
Yep. Makes sense?
So in erythemia, if you're prolonging it, it's going to even cause more further damage, right? Like the impulse is obviously more, right? In atrial fibrillation.
Yeah, in case of atrial fibrillation, there is basically no contraction, man. It's just like vibrating in its place. So.
Oh, so there's no impulse, no? Like from SA node?
Well, there is impulse, but there is no contraction. So if you check their heart rate, it will be 180. But if you check their cardiac output, it will be really low. Why? Because
Doc, I'm not understanding. This is the SA node will come. Why will it not hit the isoelectric line, Doc? It's coming so many times, right, Doc?
Wait, man. You are speaking about two pathology. You confused me. Which pathology are you asking about?
So in atrial fibrillation.
Oh, now atrial fibrillation. We stopped about the QT. Good. Atrial fibrillation. What about it?
That's also an arrhythmia, right, Doc?
Yes, no? That's a type of supraventricular arrhythmia.
Supraventricular arrhythmia.
Yes.
So in that, if we give this any of these drugs like the 1A, B, C, which prolongs the QT,
okay,
so that will come and hit it, right, Doc? That impulse.
Well, it's not the same ectopic foci. It's all depend on which ectopic foci are we speaking about. In atrial fibrillation, we are speaking about an ectopic foci that is located where?
Atrial fibrillation, Doc. It's in the pulmonary arteries, Doc.
Vein.
Pulmonary veins, yeah.
So if we speak about ectopic foci leading to torsade de bois, they will be located in the ventricle himself. Okay, so that's totally different, ectopic foci. If we speak about the flutter, they will be located near the tricuspid valve, yeah?
Okay, Doc.
So it's all about the location of the ectopic foci.
Okay, Doc, the location. Okay, Doc.
Yep.
Got it. Anything about ventricles is supraventricular tachycardia, right, Doc? Anything about?
Again?
Anything about ventricles is supraventricular tachycardia. Any epoch?
Yes. So if
like flutter and AFib.
Yeah, atrial fibrillation, flutter, tachycardia. If it was sinus tachycardia, all of these are considered as VTs, supraventricular tachycardia. Yeah.
Got it, Doc. Yeah, Doc. Even Wolff-Parkinson White, because of bundle of Kent is in the above the ventricles, right, Doc?
Yep, and when you look at these patients, what you will see in the on the thingy, I mean, the QRS complex, will it be wide or narrow?
In Wolff-Parkinson White, Doc?
Yep.
There will be a delta wave in the PR interval.
Okay, so if they do, so what happens to the QRS complex? Premature excitation, it becomes a little bit wider. But when they get the actual disease, which is why we are scared of this problema, which is like premature contraction of the ventricle, because it can precipitate to something else. What is the something else? ANVRT, yes, which is basically re-entering circuit. Yeah?
Okay.
When you get the re-entered circuit, you will have a humongous tachycardia. Yes?
Right. Yeah, Doc.
Re-entry. Yeah.
Oh, okay. Okay, Doc.
So keep in mind, Wolff-Parkinson-White syndrome, they have a short PR interval. Yeah?
Yes, Doc.
Okay.
Definitely. So
Vitamins,
can you record? Can you record it, Doc?
I already started it.
Oh, okay.
So vitamins and mineral absorption. So let's speak IFB, iron fist, bro, or whatever you want. So, so iron is absorbed as Fe plus 2 in the duodenum. I want you to know that most of the iron we eat is Fe plus 3. Okay? For the sake
Okay.
of iron to be absorbed, it must be converted to Fe plus 2. What helped this to happen? The answer is vitamin C. Okay? So you
Okay.
need vitamin C to be able to reabsorb the iron, correct?
Yeah.
Okay. So they write here iron absorbed as Fe plus 2 in the duodenum. So iron is reabsorbed in the duodenum. While folate, in the other hand, just tell me, man, if you can hear me normally like this.
Yeah, I can.
Okay, good, because I made myself a stand-up desk, which is much more comfortable. So iron absorbed as an Fe plus 2 in the duodenum, but to make it Fe plus 2, we must convert the plus 3 to plus 2 using ascorbic acid, correct?
Got it, Doc.
Okay, so folate is absorbed in the small intestine, especially in the jejunum, okay? While the B12 is absorbed mainly in the terminal ileum, okay? Can you tell me the pathway of the B12 absorption? I mean, since it comes to the mouth until it goes to the terminal
So
ileum.
as soon as it comes to the mouth, Doc, B12 is attached to the R. It's a protein R. Is it because of the amylase, Doc? The R?
The R gets cleaved off in the pancreas, in the duodenum because of the pancreatic enzyme.
No. What produces the R, Doc, in the mouth?
It comes from the salivary gland.
Salivary gland. Okay. Okay. The R comes from the salivary gland and attaches to the B12. B12 plus R complex goes to the stomach, and in stomach the intrinsic factor is produced by the parietal cell, but they are still separate, and they both enter the duodenum, and under alkaline conditions, the release of the pancreatic enzymes, it helps separate B12 and R, and then B12 is attached to the intrinsic factor in the duodenum, and they both travel to the terminal ileum, and they are both reabsorbed in the terminal ileum.
Absolutely correct. Nice. So Crohn's disease, they will get a problem where exactly?
The Crohn's disease is ileocecal junction is the common site, right?
Mm-hmm.
So they have problem with reabsorption of B12, absorption of B12.
Vegetarian?
They don't eat a lot of B12, so in 5 years, I think they become deficient.
Gastrectomy?
After 5 years. Gastrectomy, also same thing, Doc. I think they also would have problems with bile salts, right, Doc? Gastrectomy?
Yeah. That's Crohn's disease. But I'm asking about gastrectomy. Why they get B12 deficiency?
So, Doc, when they say, because the intrinsic factor is not produced.
Okay, good. What about pancreatic insufficiency?
It's not able to break down the R and the B12 complex.
Yep, makes sense?
Yeah, Doc, awesome.
Good. Vitamin B12 is absorbed in the terminal ileum along with bile salts and requires the intrinsic factor to reabsorb the B12. So vitamins and minerals may develop in minerals deficiency may develop in a patient with a small bowel disease or after resection, like B12 deficiency after terminal ileum resection in case of Crohn's disease. Yeah?
Got it.
So take a look here. The food food contains iron. So it's either a heme iron, which is Fe plus 2, that gets absorbed directly, or a non-heme, which is Fe plus 3. You make it plus 2 using vitamin C, and then you absorb it. correct?
Okay.
So when it's absorbed, it's going to be converted into ferritin, and then it gets inside of your body using something called ferroportin, okay?
Okay, doc.
Patient with hemochromatosis, they basically just have so many ferroportin, okay?
Okay, doc.
Now, the ferritin is inside of your body, and it's going to be transferred into something called the transferrin. Transferrin is going to store the iron inside of your liver, okay?
So transferrin just takes the ferritin and brings it to the liver. That's it, right? Okay, transfers.
Yes, so it's a transporter.
Transporter, okay.
Yep. So there is something called acute phase reactant, which are substances produced in case of really bad inflammatory conditions, okay? So one of them is called hepcidin. Hepcidin blocks the ferroportin here, and also the ferroportin located on the macrophages, which in the macrophages release iron. So when it blocks it, it reduces the iron release. Yes?
So what blocks it, doc?
Hepcidin.
Okay.
So hepcidin
It's not over here, right, doc? Macrophages.
No. I'm just giving it to you. So hepcidin is an acute phase reactant that decreases the amount of iron inside of your circulation, correct?
Yeah, doc.
Why would he do that? Well, if you have a bacteria in your body, bacteria has many enzymes that require iron to work. No iron, no working enzymes, the bacteria dies.
Okay, doc.
Can you repeat that?
Can you repeat? I was going to ask you, doc. Can you again repeat it, doc?
Okay, so there is something called acute phase reacting, in which in cases of inflammatory conditions, some substances are released from the liver, which help us to fight off the infection.
Got it.
For example, if we have a bacterial infection, let's say we have, I don't know, E. coli, and the bacteria have many enzymes inside of them that requires iron to function. If the bacteria does not have the iron, which is stealed from our body, it will die. Yes?
Yeah.
So your body will start to hide the iron. How can it hide the iron? By producing a substance called hepcidin, which decreases the absorption of the iron and also decreases the release of the iron from the macrophage. Yeah?
But doc, won't our body also be less with iron because absorption is less?
Absolutely. And that's why we get anemia of chronic disease.
In infections. Okay.
Yep. Make sense?
Yeah, doc. Makes sense.
Good. So Bayer's patches. Bayer's patches are located, do you know where?
In the small intestine, doc?
Yeah, in the terminal ileum also. Okay?
Okay.
So it's a lymphoid tissue, again, an encapsulated lymphoid tissue that is found in the lamina propria and the submucosa of the ileum. It contains M cells. M cells are super important for the Shigella to enter your body, okay? Which is a bacteria that samples and presents the antigen to the immune cells. So when the M cells recognizes inflammatory something like bacteria, virus, something like that, it consumes it and they present it to the immune cells, and the antigen presenting cells is going to make antibody against it. Yes?
Okay, doc.
And memory cells. So it's a way of inducing immunity. So there
got it, doc. But what happens in Shigella, doc?
Well, Shigella infect the M cells to enter your body.
But it's not going to present in the immune cells, doc, when Shigella comes?
Exactly. That's the point. Shigella is smart, so it does not allow it to do so. Okay? So you just need to know that Shigella entry point is the M cells. Okay?
Okay, doc.
So B cells is stimulated in the germinal center. We did not do immunology, so that's bad. In the germinal centers of the Bayer's patches, germinal center basically is an area that have plenty of lymphocyte in it, okay?
Okay, doc.
Okay. So Bayer's patches differentiate into an IgA secreting plasma cells. IgA secreting plasma cells. Okay, so to secrete plasma cells, you need a couple of things. We'll speak about it later. But what I want you to know that the antibody of IgA is a dimer. Okay? which
I'm
looks,
not understanding that. Maybe because we didn't do immunology.
yeah, so the antibody normally looks like this, yeah?
Mm-hmm.
So
Yeah, doc.
dimer, it's when you have two antibodies giving this area, we call it the FC portion, and it's facing each other, and that is a dimer, okay?
Okay, doc.
So the IgA, this is IgA, dimer. It needs to be released from the Beer's batches. Remember where we have IgA normally?
IgA is in the respiratory and the GI epithelium. Doc.
Surfaces, absolutely. To be secreted, it needs something called secretory proteins, okay?
Okay, doc.
It just cover it and help it to get out. So B cells is stimulated in the germinal center of the Beer's batches, differentiate into an IgA secreting plasma cells, which ultimately reside inside of the lamina propria, okay?
But where is this lamina propria, doc?
Lamina propria, if you remember, we had mucosa, submucosa, muscularis, all of these stuff, yeah?
Mm-hmm. Yeah.
So in the mucosa, where it is? Yes, in the mucosa, we had three layers. We had the epithelium, lamina propria, and muscularis mucosa, okay? So these guys are going to be located in the lamina propria.
How do I remember it? The epithelium, lamina propria. Okay.
It's just under the mucosa, you know.
Got it.
Okay, so IgA receives the protective secretory component and is then transported across the epithelium to the gut to deal with the intraluminal antigen. Let me explain that. Well, here we have your epithelium, yeah?
Mm-hmm.
Under it, we have the lamina propria, correct?
Yeah, doc.
So you have the germinal centers here that are going to make the antibody. It's a dimer.
Okay. IgA.
Yes. And it's connected with something called J chain. Okay, J chain. And it has something called secretory protein. Okay?
Okay.
Why all of this happens? To allow it to move. Without the secretory protein, it will not be moved out. Okay? So this thing is the secretory component. Okay?
Okay.
All make sense?
Secretory component. Okay, doc. Okay. It needs a secretory component to get into the gut.
Yep, this one.
IgA. Right, doc. Okay.
Got it?
Gut to deal with the interluminal antigen. Okay, doc. So the M cells present the pathogen to the immune cells, and that's why the IgA will go into the lumen, right? Doc?
Again?
So the M cells, they recognize the bacteria, doc, and they present it to the immune cells, and that will allow the IgA to be secreted into the lumen from the lamina propria, and it is going from the lamina propria to the gut with the help of secretory component of the IgA.
Done. Excellent. Okay, let's speak about bile. Can you tell me what was the function of bile?
Fat emulsification.
Okay, where it is produced?
It is produced by the liver and stored in the gallbladder, doc.
Good.
Hepatocytes. Yeah.
Which hormone helped in the contraction of the gallbladder?
Cholecystokinin, doc.
Cystokinin. Okay, so they write bile is made out of bile acids and bile salts. But what is bile salts? You need to know what is bile salts. Bile salts are bile acid with an amino acid bound to them. That makes bile salts. So when you have bile acid together with a glycine or taurine, you get yourself bile salt. Okay?
Okay.
Why they call them bile salt? Salt because salt is water soluble. Yes?
Yeah.
Okay. So other component of the bile salts, of the bile, it is going to be, so we have the bile salts is in the bile. What else? We have phospholipids, we have cholesterol, we have bilirubin, we have water, we have ions. Well, especially these two will be the most important two in all of these. Why? Because if your bile is supersaturated with bilirubin, you are going to get a pigmented stones. If it's supersaturated with cholesterol, you are going to get a cholesterol stone. Yes? So, cholesterol 7-alpha hydroxylase catalyzes the rate-limiting step of bile acid synthesis. So imagine, if I block this one, will I have bile acid?
No.
So I will have more cholesterol and bilirubin in my bile, because what is bile? Bile acid, phospholipid, cholesterol, bilirubin, and water. So if I don't have bile salts, I'm going to have a plenty of cholesterol and bilirubin. Yes?
Yes, sir.
So that can make me like other type of stones, especially cholesterol stone. Yeah? Okay. So what is the function? Tell me a little bit about the bile. What do you know about it?
So bile salts are made up of bile acids and amino acids, particularly glycine and taurine. And it's basically a salt because it needs to be water soluble for it to act on the digestion of fats. Basically, bile salts are composed of bile, bile acids, and it's also composed of the water, phospholipids, most importantly, cholesterol and bilirubin. So
Yep.
whenever there is any inhibition of the bile synthesis, that will lead to cholesterol stones or pigmented stones.
Okay.
And the rate limiting step in the bile synthesis is this cholesterol 7-alpha hydroxylase. That's the rate limiting. Meaning, if the enzyme is more bile salts. If the enzyme is less bile salts.
Absolutely. So basically, they tell you that it's water soluble, which means it has fat, which help in the emulsification process. Yeah, which is making like droplets of fat. Yes.
Yeah.
Okay. So digestion and absorption of lipid and the fat soluble vitamin. So if you don't have bile, you don't have fat soluble vitamin absorption. What fat soluble vitamin do you know?
Edek.
Okay.
ADEK.
Bilirubin and cholesterol excretion also, because they are made out of them. So body's primary means of elimination of bilirubin and cholesterol. Antimicrobial activity via membrane disruption of the bacteria inside of our intestine. Correct?
Antimicrobial activity.
Yeah, the bile is going to basically go and disturb the membrane of the bacteria, which lead to its destruction. Okay?
Okay.
So there will be decreased absorption of the enteric bile salts at the distal ileum. So, okay. They are saying that in some cases we can have decreased absorption of the enteric bile salts at the distal ileum. Remember, the bile is made out of what? Bile salts,
bilirubin,
cholesterol. The other ones are not that important, but these three are important, okay?
Okay.
So these we eliminate. I mean bilirubin and cholesterol, yes? But if we speak about the bile salts, we need to reabsorb, okay? Where do we reabsorb it? In the ileum, okay? So if the patient has a short bowel syndrome or Crohn's disease, can he reabsorb them?
No.
So that will prevent, if he cannot reabsorb them, can he make a new bile?
We need to make new bile though. The body has to make new bile.
But if he does not have bile salt, no bile salt, so?
But can the body make more bile salts though?
Well, he makes, but you need to have this enterohepatic circulation to keep sufficient amount. The body can make bile salts, but he also need to reabsorb them to have enough. So you will not have enough bile anymore, correct? If you have these problems. So that prevents normal fat absorption and may cause bile acid diarrhea. Yes?
Okay.
So calcium, which is normally bound to oxalate, binds to the fat instead. Did we speak about this?
Yeah, calcium stones, right? Doc? We spoke
Yes.
about it. I think.
So the bile salts normally are absorbed here. Yes.
Mhm.
And they say calcium, which is normally bound to oxalate, binds to the fat instead, so free oxalate is absorbed by the gut. Why? Because look, bile salts is going to get out. Yeah, it's not getting absorbed, so bile salts here. A lot of fat will go with it. Yeah, because it's not working, it just will go with it. So the calcium will go make a complex with these guys, but who will be left alone? The answer is oxalate. Okay.
Okay.
So oxalate will be absorbed and it will go to the kidney, creating a calcium oxalate stone. Okay?
So, Doc, if when we have any surgery and we remove the part of the intestine, that means the bile salts are not being reabsorbed, right?
Correct.
That means the calcium is getting bound to the bile salts and the oxalate is roaming free, so they'll also get calcium stones.
That is
Oxalate
correct.
stones.
Yes. Yes. Oxalate stones which have the envelope shape. Yeah?
Yes, Doc.
Okay. Good. Next. Bilirubin. Where do we get bilirubin from?
1 second, Doc. I just want to... So calcium usually binds after the ileum, Doc,
To the fat and the bile salts, you mean? Yes. It's after the ileum.
after the ileum. Okay. Okay, Doc.
Okay. So bilirubin. Where does bilirubin come from?
From the RBCs, Doc.
Mm-hmm.
Breakdown of RBCs.
What RBC is made out of?
Hemoglobin, Doc.
Okay. What is hemoglobin made out of?
The bilirubin, Doc.
No, it's heme and globin. Yeah?
Okay.
So it's heme and globin. So, okay, globin is what? Protein. Protein is made out
Okay,
of
Doc.
what?
Amino acids.
Okay, good. So when we destroy the RBCs, we can take the globin, make amino acid from it, and use it for something else. Okay, let's go to the heme. What is heme made out of?
Bilirubin, Doc.
No, it's made out of iron and protoporphyrin. Yeah? So take a look. This is a heme molecule. Can you see the iron in the middle?
Yeah, Doc.
That's iron. The rest of the structure, we call it protoporphyrin. Okay?
Protoporphyrin.
Yeah, let me show you the dictation because I suck at dictation. Protoporphyrin. Yeah. So you can see that we have, oh yeah, iron protoporphyrin. Can you see? This is the iron and the structure around it is the protoporphyrin. Okay, so when we remove the iron, we will have protoporphyrin alone. Yes?
Okay.
So the iron, we can use it for some other reaction, but the protoporphyrin can be converted into something else. So protoporphyrin can become biliverdin, okay?
Okay.
Which eventually can become bilirubin, okay? Do you understand that concept?
I'm just writing it down. Okay.
Mm-hmm.
Got it.
Okay, tell us.
So heme is made up of iron and protoporphyrin. Protoporphyrin is converted into biliverdin and then into bilirubin.
Done. Good. But it's unconjugated bilirubin, indirect bilirubin, okay?
Unconjugated, or indirect. Same thing, right? Doc?
Yep. So heme is metabolized by heme oxidase to biliverdin, which is subsequently reduced into bilirubin. Unconjugated bilirubin is removed from the body by the liver. How? Remember something called the cytochrome B450?
Yeah, Doc.
Which zone of the liver it was?
I think the innermost part, right? Doc? Zone 3?
Yes. And it's the centrolobular part, yeah, around the central vein. And
Yeah, that's zone 3, right? Doc?
Uh-huh. And this enzyme has two phases of working. Phase 1 and phase 2 we'll study it in pharmacology. But in phase 2, it has a process called conjugation that occur, okay? And
Okay, Doc.
this process of conjugation happens using an enzyme called UDP glucuroneal transferase. UDP glucuroneal transferase, okay?
Okay, Doc.
So the
Can
yes,
we again start over, Doc?
absolutely. So let's have RBC. It has hemoglobin. So the globin going to become amino acid when destroyed, of course, the RBC. And that's used for, well, building up stuff. Now the heme. The heme has iron and has also what? Protoporphyrin. Protoporphyrin becomes biliverdin by an oxidase, and then from biliverdin becomes indirect bilirubin. Yeah?
Yeah, Doc.
Then it keeps going to the liver. Zone 3 of the liver, containing the cytochrome B450, has an enzyme called UDP glucuroneal transferase, which conjugate the unconjugated bilirubin. So instead of indirect bilirubin, you will have direct bilirubin. Okay?
Okay.
The direct bilirubin, then it will have some story, but until now, all good?
Yeah, Doc.
Okay. So let's take a look here. They say unconjugated bilirubin is removed by the blood from the blood by the liver, conjugated with a glucuronate, okay, and excreted in the bile. Good. So the bile contain 3 main substances. What are they?
The bile contains 3 main substances, which is bile salts, cholesterol, and bilirubin.
Yep.
Conjugated bilirubin.
Yes. Okay, so direct bilirubin is conjugated with the glucuronic acid by the help of the UDP glucuroneal transferase enzyme, and it's water soluble. Okay, so when I say it's water soluble, it means it can go out with the urine, correct?
Yes, Doc.
So that can change the color of the urine, correct?
Yeah.
Okay, so in cases of post-hepatic obstruction, direct bilirubin will be higher, correct? Like
Yeah,
a
Doc.
stone. And that can lead to changing of the color of the urine.
Yeah.
Okay. Indirect bilirubin,
So how does it go? Like it gets released into the blood, Doc, if there's an obstruction over there?
yeah, basically, if there is an obstruction right there, it will be increased and then it will be absorbed from the bile duct. Yeah? It will go to the blood and then it will be released into the urine.
Okay. So direct.
Uh-huh.
Yeah.
So indirect bilirubin, it's unconjugated, it's water insoluble, which means the same as saying it's fat soluble. Yes? Since it's fat soluble, it can go to the brain. Yes?
So, Doc, before the UDP glucuronase, it's unconjugated, right, Doc?
Correct.
So that is not water soluble. It's water soluble after the UDP?
So before the UDP, it's fat soluble. Yeah?
Okay.
If it's fat soluble, it can cross the blood-brain barrier, correct?
Yes, Doc.
Crossing the blood-brain barrier can lead to something called kernicterus.
Okay, Doc.
Okay, good. So let's take a look. RBC, heme, unconjugated indirect bilirubin. By the way, the unconjugated indirect bilirubin, for the sake of it to move to the liver, it needs a carrier, which is albumin, okay? So it's the indirect one. All good?
Yeah, Doc.
Okay. So in the liver, UDP glucuroneal transferase, which is located at zone 3 in the cytochrome B450, is going to conjugate it into, well, direct bilirubin, which is water soluble, and then it's going to be released into the gut. At the gut, it's going to be converted to something called aerobilinogen. Aerobilinogen, some of it will be reabsorbed and some of that will be secreted. A little bit of it will be absorbed. The most of it is going to be excreted as a stercobilin. The stercobilin is the thing that gives the feces their color, the brown color of the feces. Okay?
Yeah, doctor.
So the reason that the feces have their color brown is the stercobilin. So 20% of it would go through the enterohepatic circulation and come back to the liver, because after all we need bilirubin. And a little bit of it will go to the kidney, which gives the urine its yellow color. Okay?
Okay.
All make sense?
Yeah, doc. So only 20% is reabsorbed, doc?
Yes.
And 80% is excreted.
Yeah, to
So
the feces.
only 20% of bilirubin, not the bile salt, right? Bilirubin.
Bilirubin. Yes, we are speaking about bilirubin now, not bile salt.
Okay. So bilirubin, and at 20% or 90% is reabsorbed, 10% is again excreted. Okay.
Good?
So basically we are only getting the 18%, that's it.
Yep.
Okay, doc.
Okay, done with physiology. Yay!
Okay, doc.
Nice. Okay, let me just check one thing. 1, 2, 3, 4, 5 pages. Wow, nice.
Yeah, doc.
Okay, what should
Can
we
you
do?
stop it and can you upload it, doc?
Okay.